Welcome everyone to this patient-focused webinar. My name is Sydney Stevens from Insight Tech, and I'm pleased to be a part of today's virtual educational event. Please be patient as we take a few more moments to allow everyone to get signed on, and the presentation will begin shortly. Welcome everyone to this patient-focused webinar. My name is Sydney Stevens from Insight Tech, and I'm pleased to be a part of today's virtual educational event. Please be patient as we take a few more moments to allow everyone to get signed on, and the presentation will begin shortly. Okay, it looks like we have a great number of attendees signed on, so let's go ahead and begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from both Dr. Langevin and Dr. Diaz as they discuss focused ultrasound as a treatment option for patients diagnosed with essential tremor or tremor-dominant Parkinson's disease. As questions arise during the presentation, please utilize the Q&A button that is located at the bottom of your screen, and we will have time after the presentation to answer all of the questions that are asked within the chat. Now let me begin by introducing you to today's presenters. Dr. Langevin is a board-certified and fellowship-trained neurosurgeon specializing in the surgical treatment of movement disorders, epilepsy, and psychiatric conditions. He was selected as a 2016 Super Doctor Rising Star and achieved the Super Doctor designation again in 2017. He has extensive experience in neuromodulation to treat conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, and obsessive-compulsive disorder. He is a director of the Restorative Neurosurgery and Deep Brain Stimulation programs at the Pacific Movement Disorders Centers located at Providence St. John's Health Center and Providence Little Company of Mary Medical Center. Thank you so much, Dr. Langevin, for being here this afternoon. Now we have Dr. Diaz. Dr. Diaz is a board-certified neurologist with fellowship training specializing in movement disorders. She also has specialized trainings in the evaluation and programming of deep brain stimulation as a treatment for Parkinson's disease, essential tremor, and dystonia, as well as the therapeutic administration of Botox injections for non-cosmetic indications such as focal dystonia and limb plasticity. Her research focuses on industry-sponsored clinical trials in Parkinson's disease and other collaborative clinical projects in the field of neurodegenerative disorders. Please welcome Dr. Diaz and Dr. Langevin, and thank you so much for presenting this evening. I want to remind everyone to please utilize that Q&A button that is located at the bottom of your screen so we can get those questions answered. And Dr. Langevin and Dr. Diaz, the floor is now all yours.
Great, thank you, Sydney. So good evening, everybody, and thank you for joining us today. Today is going to be a two-part series. As Sydney just introduced us, I am a neurologist and a board-certified movement disorder specialist. So I'm going to be talking about the neurological side of some of the conditions that I treat and MRI-guided focused ultrasound, and how I get to that point where I have discussions with patients about this treatment and who would be a good candidate. And then I'm going to hand it off to Dr. Langevin to discuss a little bit more about the procedure and the actual apologize, my screen does not want to move. There we go. So I'm going to try to go over two of the conditions that are approved for focused ultrasound. These are essential tremor and Parkinson's disease, and I'll talk a little bit about their diagnosis, their clinical spectrum, as well as the medical treatment that we have. Talk a little bit about what are the surgical options that we consider when I'm seeing these patients in clinic, and who's suitable for them from a neurological perspective. And then I'll hand it over to Dr. Langevin to go into the nitty-gritty about focused ultrasound itself. So let's start with essential tremor. So this is actually considered the most common movement disorder, and the International Essential Tremor Foundation estimates that there's about 10 million people in this country living with essential tremor. It is a condition, as you'll see in the video, that causes tremor in the hands, and it's a type of tremor we call an action tremor, meaning that when the hands are in motion, is when the tremor comes out, and can many times occur while people are doing their daily activities, eating, writing, getting dressed, brushing their hair, putting on makeup, dressing. So we need tremor in the hands to make the diagnosis, and it's usually both hands that are involved. About 20 to 30% can also experience tremor in their heads, either like a no tremor or a yes tremor, and about 10 to 20% of people can experience voice tremor, either when they get really emotional or just part of their conversation. Tremor tends to worsen in certain scenarios if people are under stress, if people are feeling anxious, if they've drank too much caffeine or drank too much sugar. Many times this can worsen the tremor temporarily. And despite the fact that it's a very common condition, we still don't really know what causes essential tremor. We do know that genetics likely plays a role for this condition, and about 50% of people can tell you that they have other family members that have had tremor. So, this tremor, despite when we learned about it in medical school years ago, it was called benign essential tremor. We've taken the benign out of it. And the reason is that this tremor can over time really start to affect people's lives. So they have done surveys over the years asking people with essential tremor, what we shorten as ET, as to how tremor impacts them. And they've come to learn that, as tremor progresses, about 80% of people experience tremor that impacts at least one of their daily activity. This could be dressing, eating, bathing, using a pen, using eating utensils. About 50%, 15% of people report that tremor can affect their job, depending on the job that they do. If it requires a lot of manual dexterity, about 45% of people say that it impacts their ability to do their hobbies, whether it's golfing, whether it's painting, ceramics, pickleball. So, that can also be very intrusive to people. About 60% of people get embarrassed by the tremor and sometimes actually start avoiding family events, social events, and start withdrawing from seeing their friends and family. And of course, this can many times lead to depression and anxiety, which is also very comorbid in this condition. As the tremor continues, so over the years, the amplitude of the tremor can increase, and this may really make an impact in their ability to function. And some people start requiring help from others to do some of their mundane daily tasks. So how do we diagnose essential tremor? Well, unfortunately, because we don't quite understand it, we don't have a cause for it yet. We don't really have any specific diagnostic tests for it. It is still based on a medical history and examination, and we have people do some of the tasks that they normally do at home to see if we can bring out the tremor. We have them hold out their hands in different positions. We have them move and point from their nose to the finger. We have them write in clinic, and as you can see, many times have them draw spirals or write their name or write a sentence where the tremor can come out. And usually that gives us an idea of the type of tremor that we're dealing with. Certain factors can be supportive of this diagnosis. So if somebody has a strong family history of tremor, multiple family members, that's usually a good clue that we're dealing with essential tremor. And oftentimes, and people always laugh when I ask them this question, does your tremor get better with alcohol? We're not trying to assess, how much alcohol you're drinking. It is actually a supportive criteria for this type of tremor. Alcohol works at certain inhibitory channels in our brain. And many times if your tremor gets better with alcohol, it can tell us if we're looking at essential tremor. Even though we don't have a diagnostic test, we often have to do some testing. We exclude other conditions. For example, we'll do a good get a good idea of how much sugar and caffeine a person is drinking. Sometimes people are drinking multiple cups of coffee a day or drinking multiple Cokes a day that could be worsening their tremor. We usually, if the primary care doctor has not already done it, we'll do a good screen for other metabolic conditions, liver or kidney disease or thyroid conditions that can worsen tremor. We'll do a good screen of all the medications that they're on. There are definitely medications that can aggravate tremor. I wrote a few of them down here. People that are on steroids chronically or are taking a lot of asthma medications such as inhalers, people that take amphetamines for ADHD or for daytime sleepiness. Some psychiatric medications can sometimes bring out tremors. So we do a good medication screen. And of course, if people become of an age, 50 and over, many times Parkinson's disease can be confused for essential tremor. So that's one good reason to see a neurologist if you're over the age of 50, is to kind of make a decision whether this is Parkinson's disease or essential tremor. And I'll talk a little bit about that in a second. So how do we treat essential tremor? Well, we have a variety of medications that are available, and unfortunately, the needle hasn't moved much in our treatment of essential tremor over the last couple decades. Again, mostly because we don't quite understand the condition, and so we haven't been able to come up with more targeted medical therapies. We have first-line medications, propranolol, which is an old beta blocker, also goes by the name of Inderol, and it's actually the only one that is actually approved for essential tremor. But we have also primidone, which both are considered first line and both equally effective. If people cannot tolerate these or people don't get enough relief, we can either add or move on to some second line agents, topiramate or Topamax, zonisamide or Zonegran, and some of the other beta blockers in the same family as propranolol can also be effective and sometimes are used by some of their other physicians, such as a cardiologist may put somebody on metoprolol or atenolol for their hypertension, their high blood pressure, and that can also be effective for their tremor. So we usually cycle through these and see which ones people can get more benefit from, or sometimes combine them. Sometimes propranolol and primidone have been shown to be synergistic, and we'll do a little bit of both together to see if we get a little bit more than just each one individually. In addition to medications, there are assistive devices that are available. So there are weighted utensils that people can access, heavy weighted forks and spoons and knives and heavy bottomed cups that, the heavier something is, it weighs down the tremor. There are gloves that people can get online that have weights in them that also help to kind of dampen down the tremor. There are adaptive tools to help people open jars, special kind of knives to help people cut better. There are snap clothing that don't involve ties or buttons that can be a little bit easier, slip-on shoes. There are also large bore pens or programs that people can put on their phone or tablet to help cancel out tremor. And there are also some wrist-worn devices that people can get to help dampen the tremor. But again, none of these are enough to get rid of tremor when people have, a good amount of tremor that is intrusive in activities. And many times I will send people to see an occupational therapist to help strengthen, to see how we can use some of these tools to improve their daily functioning. I also will send people to, not only occupational therapy, but also physical therapy and sometimes even speech therapy if they have a lot of vocal tremor, and also to strengthen and make sure that they have good strength to do some of the things that they need to do. So these are all the things that we look at when we're treating somebody with essential tremor. But here's the problem. When people have good amount of tremor, moderate to severe tremor, the problem is that studies have shown that medications can only at best reduce the tremor by about 50%, and about 50% of people don't get any relief from these medications. These medications also, they're not clean. They can have their potential side effects. So propranolol, as being a beta blocker, can make people feel a little sleepy, a little dopey, a little dizzy. It can lower blood pressure. Same thing with primidone, can make people tired and sometimes have a little bit of mental fog. Topamax, gabapentin, zonisamide all have the same issues of sedation and maybe a little bit of cognitive slowing. Primidone, we have to be a little careful with. It's metabolized in the liver. And so sometimes if people are on medications that are also metabolized by the same enzymes in the liver, there can be a problem and it can lower their effective medication. So if people are on blood thinners, if people are on hormonal therapies, if people are on certain antibiotics or antivirals, even vitamin D and vitamin K, if we put them on primidone, it's going to amp up the metabolism of these drugs and make them less effective. So always very important for us to screen what medications people are on if we're considering primidone. And so what happens is, because we can only get so much from medications, and because of some of these side effects or potential interactions, what happens is many people just end up living with the tremor and don't seek more help, because they know that up until now, there hasn't been much more than this. I'm going to flip a little bit before I move on to surgical therapies, and I'm going to talk a little bit about Parkinson's disease. So Parkinson's disease is much less common than essential tremor. So the Parkinson's Foundation estimates there's about 1 million to 1.5 million Americans that are living with Parkinson's disease, about 90,000 that are diagnosed every year. The classic symptoms of Parkinson's are muscular stiffness, slow in their movement, tremor, and changes in gait and posture, walking and posture. So with the classic sort of picture that we see clinically are people that have a loss of facial expression, of low volume voice, they don't move effectively, they're slow in their movement, they're rigid in their movement, they may have stooped posture. Now, tremor is one of the classic symptoms of Parkinson's. It tends to be a rest tremor, meaning when people are completely at rest, they're distracted in talking or they're watching TV, tremor comes out in a hand, in a leg, or maybe even in the chin or the lips. About 25% of people can have what's called tremor-dominant, where tremor is really the most prominent symptom. And it's more than just a rest tremor. Many times it spills over into action tremor, which is it happens during activities. And then tremor over time can be very disruptive. Again, with Parkinson's disease, we have a variety of medications that we use. There are the classic dopamine-based medications, and these are because in Parkinson's, people have low brain dopamine, so we're trying to supplement that. We use a classic one called carbidopa levodopa, or we have synthetic forms of dopamine called dopamine agonists. We have a variety of adjunctive medications that we add to our dopamine-based medications to boost up their effect if needed. And then we have a couple of other medications that we use. The problem is when people have a lot of tremor, the Parkinson's medications sometimes don't get at the tremor. They're good at fixing the other symptoms of Parkinson's. People are stiff, people are slow, but tremor can sometimes be, especially when there's a lot of tremor, refractory to our medications. We also use a lot of our rehab specialists. Again, I send people to physical, occupational, and speech therapy to strengthen, to see how they're completing their daily tasks and how we can improve their daily function and with or without tremor and improve their voice and communication. So we'll use a combination of these therapies for medical treatment. Now, one of the issues that happens with Parkinson's when they're on the dopamine-based medications, which almost every Parkinson's patient is at some point, is that over time, people start having what's called the complications of therapy. What this means is these medications are used by the brain to try to make more dopamine or act like dopamine, but because the brain is changing over time and their condition is progressing, these medications start lasting less and less, so they need more frequent dosing, and they start having involuntary movements like Michael J. Fox, what we call dyskinesias, these are what we call the complications of advanced Parkinson's and their treatment. So, at this stage, many times people are taking a lot of different medications, sometimes very frequently, to try to cover their symptoms of Parkinson's. So At these points, this is when I start thinking and maybe having a discussion with my patients about some of the surgical options that we have available for essential tremor and for Parkinson's. So when do I start introducing this to patients? Well, we have, what we are reasonably confident that we're dealing with either a diagnosis of essential tremor or Parkinson's disease. If somebody is just seeing their primary care doctor for these conditions, especially if they're going to consider, any surgical therapy or more advanced medical therapy, they should see a neurologist or a movement disorder specialist to make sure that this is the diagnosis that they have. We're looking for patients that have tried at least a couple of the different medications for either one of these conditions, and either they're not getting the benefit that they need out of them, or they're experiencing side effects that won't allow them to stay on the medications. And their symptoms, whether it is bothersome tremor or it is Parkinson's disease, where they've reached that stage of motor complications, and these symptoms are starting to become intrusive and causing disability and affecting their ability to do things on their own and their daily activities, that's when we start talking about some of their surgical options. We have two main surgical options that are available: deep brain stimulation, which is the surgery of Parkinson's that's been around for about 25 years at this point. It is both essential tremor and for essential tremor and Parkinson's disease. This is a true surgery that involves surgically implanting a system, electrodes in the brain, a wire under the skin, and a pacemaker-like battery under the chest wall skin here. And what it does is it delivers electrical stimulation to the brain in certain targets that are known to treat effectively the symptoms of these conditions. But it is a surgery. It does require that people go under anesthesia. It is a night's stay in the hospital. And after you get the surgery, you have to continue to follow with your neurologist or your movement disorder specialist to program the system over the life, over patient's life as their condition progresses, because none of these are curative. They're really to try to tackle the symptoms as best as possible. Focused ultrasound is now our newer surgical therapy. It is also approved for essential tremor, and more recently was approved for Parkinson's disease. This one is not a surgery, but it is done by a neurosurgeon like Dr. Langevin, and it involves the use of high intensity ultrasound waves that are guided by the use of an MRI to create a little lesion in the brain for treatment of tremor and some of the motor complications of Parkinson's. It is minimally invasive. It does not involve any cutting. It's incisionless. It's an outpatient procedure. And they call it one and done, meaning that you get it done, and then there's minimal follow-up for tremors specifically. Who's suitable for this? Well, as I mentioned, somebody who's got a confirmed diagnosis of essential tremor or Parkinson's disease. They have to be at least 22 years old for essential tremor, 30 years old for Parkinson's. Their tremor limits for either condition limits their ability to perform their daily activities, or they're in the advanced stage of Parkinson's disease and are experiencing those motor complications I've mentioned. They've tried at least 2 types of medications. As Dr. Langevin will discuss, that this involves somebody being in an MRI scanner during the procedure. So I always, before I refer somebody to Dr. Langevin, make sure that they understand you will be in an MRI scanner. We need you to be able to lie flat, to be able to fit, to not be claustrophobic, because unfortunately we cannot give you sedation during the procedure, and you need to be able to communicate. You're awake and we're talking to you during the procedure. So in summary, from my perspective, essential tremor is a very common condition with tremor that can interfere with somebody's daily activities and really impact their quality of life. At best, our expectation with the medications we have available is a 50% reduction in their tremor, but oftentimes patients are unable to tolerate them, or only tolerate them to a degree. So many people that have bad tremor, they just live with it. With Parkinson's disease, about a quarter to a half of people can have really bothersome tremor. And as the disease progresses, they get the motor complications. And, when we've exhausted our medical options, we have the discussion about surgical therapies, such as focused ultrasound. And for some people, that can be a very effective option. So I'm going to end my talk here, and I'm going to hand it over to Dr. Langevin.
Thank you, Dr. Diaz, and thank you everybody for joining us tonight for this webinar. So I'm gonna share my slideshow now. So like we discussed, my portion of the presentation is to discuss more the technicalities of focused ultrasound. So like a little bit how it works and how we perform it. So what to expect if you were to undergo the procedure. And obviously going over the risk and benefits, like why would you consider focused ultrasound versus DBS versus, continuing medical therapy. And at the end, as we said, we'll take the questions. I think there's a Q&A box where you can enter any questions, and we'll go through them once we're completed here. Although focused ultrasound is new, especially in the South Bay, so we're the only center currently offering it. It's actually been around for a while already, so like it kind of speaks a little bit to the safety profile of the procedure, but also the longevity of the treatment. So the first patients were actually treated like 20 years ago currently. And the FDA approval was obtained in 2016, so like a little about 10 years now. More recently, there's been a lot of advancement in the field. So like the second side has been added as an approval. There's been coverage from the insurance company, which really like increased the use of the therapy in the population. And more recently, there's been approval also for Parkinson's disease. So we think that it's just essentially going to continue to grow. This video kind of shows our presentation, a little bit of what to expect and how the technology works. But what I want to bring your attention is that, everything is performed into the MRI environment. So essentially from a patient perspective, aside from the frame, like the rest of the procedure is very similar to getting an MRI. But essentially the patients are inserted into the MRI, they undergo the brain scans, and from those images we plan the target location, so the area there that controls tremor. The machine then delivers the ultrasonic waves to that one area, and that provides a therapy to treat the tremor. So we initially provide a test dose to make sure that we're treating the tremor properly and that the patients don't have any side effects, so that test dose is reversible. But once we're satisfied with the results that we're obtaining, then we deliver the final dose that provides the long-term or permanent lesioning effect. So this is some example of before and after treatment. So Dr. Diaz showed, in the clinic, we oftentimes have our patients draw spirals as baseline, but you can see like a drastic improvement of the tremor and how the patients are able to write, draw on still actually in the MRI environment before leaving the hospital on the day. But in essence, it's non-ionizing the energy that's being used to create the lesion because it's ultrasonic. So there's no worries about it creating cancer or having any detrimental effect. And the target that we select for the tremor is the same that we have been using for many years with DBS. So we're very averse and used to finding that specific target inside the brain. And it's simply a different way of addressing the problem, essentially. This video kind of captures some of the effect of, from essential tremor, but also like the benefits that this patient has received from focused ultrasound. So I'll just play it here briefly.
I've always had essential tremors since I was a child. In a work setting, I need to write, I need to be able to sign contracts, I check into hotels, and the shakes hurt. I mean, it makes it very difficult for me to get through those parts of life. I found on the internet the procedure involving the focused ultrasound, and it was really compelling. I don't have to have a traditional brain surgery. The first thing I'd like to do after the treatment is to sign my name. It sounds really simple, but it's a wonderful thing for an individual who's struggled to sign your name when you're trying to check into a hotel, rent a car, or do anything. So if I can sign my name without having my hand shake, that's going to be wonderful.
So it gives a little bit of an example. So, obviously the type of patients that we offer the procedure to are the ones that have like a lot of disability and their quality of life is impacted by the tremor. So difficulty with writing, difficulty oftentimes eating and using utensils. Some of our patients also have like hobbies that require higher level of precision with their movements, like sewing or soldering. So those are all examples where we can really impact patients' life and their quality. So I mentioned that the indications have been increasing over the past years for the focused ultrasound. So currently there's more than 20,000 procedures that have been performed, and the numbers are increasing significantly every year at this point. There was always a question when focused ultrasound was introduced years ago whether or not the effects would have longevity, meaning that, with the tremors recur like down the line, right? So it's one thing to leave the hospital that day with tremor control, but like what happens down the line? And so now we have experience, over 10, 15 years and almost 20 years. And so the results are really encouraging. So we see the multiple publications and initial tremor improvement of in excess of 70% tremor improvement is maintained at 5 years with no additional side effects or problems. Some of the side effects and issues that patients can experience immediately after the procedures are headaches, as you can imagine, both from the procedure of placing the frame, to immobilize the head during the procedure, as well as sometimes the ultrasonic wave can create some headaches for certain patients. Typically, it's something that's well controlled with over-the-counter medications like Tylenol or ibuprofen, ice pack on occasion. Other side effects that we ask the patient to watch for is gait imbalance that may occur after the procedure, usually short-lived, or numbness and paresthesia, so that we check for that while we deliver the test dose. So typically those side effects, if they do occur, are short-lived and related to swelling that happens after the lesion is performed inside the brain, and it improves within a few days after the procedure is completed. But the benefits of the tremor is persistent over time. And these are some of the more scientific results where you can see on the left-hand side disability scores. The blue bar is the patients who are undergoing the focused ultrasound treatment. The red bars are the patients who had sham therapy, so that was necessary to obtain the FDA approval. And so you can tell how the disability drastically improves after the treatment is performed, but not in those patients who did not have the treatment. And eventually, after 3 months, those patients who had that sham procedure then underwent the actual therapy, and then you can see how they catch up, and everybody has a significant improvement in their quality of life down the line. I mentioned about the longevity. So this study here demonstrated the reduction in tremor. So that's at baseline here, the severity of the tremor reaching a score of approximately 4. After the treatment, it drops down to 1, and that's maintained up to 5 years for the duration of that study that was performed. So now what to expect on the treatment day. And so this will navigate this video here will carry you through some of the steps of the procedure.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
And so the duration of the time when the frame is placed until the completion of the final therapy is about an hour to an hour and a half, depending on how many test doses we want to perform and making sure that the tremor is improved.
During the
So just going over the steps, the one step that's actually not shown here is what happens prior to the procedure. So we see you in clinic and we obtain a few scans. One of them is a simple MRI that's going to help us out planning the actual target, for the lesion and avoiding any important structures, with the ultrasonic waves. A second one is a CT scan. That's important. So like we actually measure the density or how thick the skull is. And that allows to confirm that the ultrasonic waves can enter to the target area efficiently and so that we can perform the procedure safely without pain. So that's performed before you come in for the procedure. Then on the day of the procedure, we shave the head because we cannot have any bubble of air between the environment of the ultrasound and the scalp or the skin. So essentially that space has to be filled with water completely without any gaps. So the only way to ensure that fully is to perform a complete shave. And then we place the frame, which sits on the skull. So it involves 4 pins, so like 2 in the front, 2 in the back, where we numb up the skin so you don't feel any pain. The pins are inserted through the skin with small punctures, and they sit on the skull, essentially, so penetrating the skull slightly to avoid any movement. Once the frame is in place, then you obtain the scans that it was shown on the video. And then we work those scans. We fuse them, we merge them with the scans that we have obtained before the procedure. And we measure the location that we want to treat. Then we do the target dose. And then we test with spirals. Oftentimes we have you pretend drinking from a cup to see if your tremors are improved. And once we are happy with the location and the effects that we're seeing, then we deliver the higher dose radiation, the ultrasonic waves to treat the tremor. Some of the benefits of focused ultrasound, over the DBS, right? So like both therapies have like a high level of control of tremor. However, there's something to say about not having an implantable device, inserted. So there's less maintenance. So with the implantable device, you have to have surgery typically every 3 to 5 years to replace the pulse generator that's depleted. So like the battery inside is depleted depending on how much energy you're using for the stimulation. And so that requires a small procedure, but you still have to come into the operating room and undergo some form of anesthesia to open prior scars, remove the device, and insert a new one. You have the option of having a rechargeable device now that limits the amount of surgery that's needed. So the rechargeable device is good for at least 15 or 20 years. However, then you need to remember to charge the device at least once or twice a week. So it takes about 15 minutes, 20 minutes, and it's done wirelessly without poking the wound or the skin, but it's still something that tethers like some of the patients. The nice thing with focused ultrasound is that there's no worry of having any device. So once you're going through the TSA at the airport, it's not going to beep. If you're getting through the metal detector at Walmart or different the stores, it's not going to alert. There's also no interference. There's always a concern with the DBS device that perhaps some strong magnets like an MRI may interfere with the programming of the device or reset it to manufacturing mode. So obviously, once you don't have the implantable system, you can live more freely without having that to worry about. For those patients who perhaps had infections in the past, so we had patients who had DBS, did really well for many years, but with perhaps a battery change, the device, the implant got infected. Sometimes patients get an infection somewhere else in their body, and the infection spreads to the device, and the DBS system has to be explanted. So for those patients, focused ultrasound is probably a better option to consider because then there's less risk of having a recurrence of that infection. If you're a patient, you're someone who has or you're prone to having infections for a reason or another, perhaps some patients are using immunomodulation treatment either for rheumatological problems, so treating like arthritis, for example, or sometimes cancer therapy. And so in those cases, if you need those medications and it reduces your immunity, then the focused ultrasound is a good option because, again, you're going to have less risk of having problems. Or if you have issues with anesthesia, so namely like cardiac problems, pulmonary issues, um, so that can raise your risk of having an issue around the time of the surgery. And focused ultrasound provides a better profile for safety in that case. We also have patients who need chronic use of blood thinners, for example, and sometimes we can stop those safely for an extended period of time to place the DBS, so like 2-3 weeks of time. But for some other patient, the cardiologist, will tell us like, for this patient, it would really increase their risk of having a heart event, if we were to stop for that duration. And so with focused ultrasound, we do have the option to limit the amount of time that we withhold the blood thinners. So that it also improves the safety profile. This other video shows, right off the bat, right? So like the patients are still here in the environment, and you can see how like their tremor is being affected significantly before they go home. More recently, so I mentioned the FDA approval has allowed an extensive like insurance coverage. So CMS is approving the device. And usually when Medicare does, the private insurance follow through. So that's what we have been seeing. And so like most of the insurance companies are improving the procedure. Occasionally it does require what's called a peer-to-peer, which is that there's an initial denial, but they have a window of time when they provide us with the opportunity to speak with the doctor reviewing the request on the insurance side. And so oftentimes when we speak with them directly, then they understand what's going on and why we feel like focused ultrasound is the best option. I mentioned also there's a lot of development in the field of focused ultrasound. One that was really exciting is the second side. So with the therapy, what we have to mention is that on the day of the procedure, only one side of the brain is treated for safety reason, which means that when you leave that day, your tremor is significantly improved by over 70%, but only on one side of your body. So typically we select the more disabling side, obviously, generally speaking, like the dominant hand. However, now there's approval to treat the other side. We do wait 9 months between the two treatments to make sure that everything has healed properly on the first side and that there's no lingering side effects like those paresthesia and gait imbalance that we discussed. So we want to make sure that the patient is completely over that recovery And then we can safely proceed with the same treatment, but affecting the other side. What the results have shown is similar tremor improvements of approximately 80% with maintenance over time. The quality of life improvement tends to be much higher after the second side, and that's because if patients gain function of both hands, then it improves their quality of life even more than gaining one hand. So we see a profound quality of life improvement after the second side surgery for those patients who have disabling tremor affecting both hands. The side effects are similar than what we see both with DBS and with single site focused ultrasound. So it's numbness or paresthesia, ataxia or the gait imbalance, and some speech impairment. And so those side effects also improve over time as healing occurs and the swelling around the side of the treatment is resolved. The trial that allows Insight to obtain approval included like 51 subjects, and you can see the age of about 73. So for those patients, and significant improvement, of tremor after the therapy was performed. And we briefly mentioned, so now that there's a new indication for Parkinson's disease as well. So there is an indication for Parkinson's disease on the tremor side. Now, Insight just recently received approval for Parkinson's disease, and including the other symptoms of Parkinson's disease, like namely slowness of movement, the tremor, obviously, but also the rigidity. And so a different site of the brain is being treated. So again, similar locations where prior lesions were performed with using other therapy in the past. So now we can apply focused ultrasound more safely, because again, we can test the patient during the procedure with a test dose that's reversible to make sure that there's no side effects. And so the results there are showing a very encouraging and showing a significant improvement in the symptoms of Parkinson's disease, as you can tell with that blue bar and this yellow bar here at 1 year interval, where there's an improvement in the tremor by 91%, the rigidity, as well as like the slowness of movement by 50 to 60% improvement. And so again, that's without having an implantable device in the body. So like it's pretty significant for the patients. So in summary, focused ultrasound does improve quality of life by reducing tremor for those patients with essential tremor, tremor-dominant Parkinson's disease, and emerging approvals now for like Parkinson's disease and other symptoms like rigidity and slowness of movement. And as I mentioned, some of the advantage is that it's performed without an actual incision, without penetrating the brain, with a probe, so less chance of having bleeding. And it's performed without anesthesia. So for those people who have increased risk related to anesthesia, related to cardiopulmonary conditions, and there's also no implantable device to maintain or to worry about. So for those patients who have issues with their immune system, are at risk of having infections, or have difficulty like with maintaining a device or interrogating the device using technology like cell phone or device that are similar to that. And so with that, I think we're going to be ready to take any questions for the last 5 to 10 minutes.
Yes, well, thank you so much, for, Dr. Langevin and Dr. Diaz, for presenting this afternoon. That was a very informative presentation, and I appreciate your time. Will you go ahead and share that slide with contact information in case anyone would like to reach out to you guys? The team at Little Company of Mary is great, so please reach out to them and take a picture of this contact information, write it down. And if we don't get your question answers today, I'm sure you can reach out to any of these contact information or any of these contact numbers, and they can get those questions answered for you all. So let's go ahead and start with some questions. We have quite a few in the chat. So I'll start with the first one. Does a knee replacement forbid using focused ultrasound for tremor? The surgery was in 2023.
No, that shouldn't be a problem. So that question comes up, quite often for surgical implants, that are metallic, as well as like cardiac pacemakers. So we work case by case basis with the radiologist in our department to confirm the safety. Sometimes if it's an implantable device like a cardiac pacemaker, we have to involve the device manufacturers as well to confirm the safety. But in general, if the device is MRI safe, then it's also compatible with the focused ultrasound because the main problem is the MRI, not the ultrasound itself.
Correct. Will focused ultrasound affect the leg? I have tremors in my foot.
Yes. So the area that we treat in the brain for the tremor controls essentially the tremor for the face, the hand, and the legs. Now, the highest control of tremor is typically in the extremities, mostly in the hands, but also in the leg. The facial tremor tends to have a lower amount of like control with the treatment, and typically will require bilateral treatment. But the leg, yes, we should see a reduction in tremor.
This person is saying that they take medication and they feel okay, and they work okay, but they feel horrible when they're on them. We see this a lot. Can I get this treatment and stop my medication?
I'd say for essential tremor, and Dr. Diaz, feel free to chime in. I'd say that the majority of people who undergo focused ultrasound or DBS will completely stop the medication afterwards because the benefits that you get from the tremor control with focused ultrasound is so much greater, like in excess to what you would obtain with the medication, that it doesn't really make sense to continue the medication. Like there's not going to be like significant benefits from doing that, and the side effects will still be present. So yes, majority of patients will stop. Now that's different for Parkinson's disease, where the majority of patients do continue their medications after treatment. Sometimes they can be reduced by a few percentage, like in frequency and in dosage. But for essential tremor, yes, the expectation would be to stop the medication.
Is there an age limit? This person is a healthy 80, but they would like to know if there's an age limit involved.
No, we don't have like an age limit per se. We take it case by case basis. And I just want to bring your attention that even in the clinical trial where they obtained FDA approval, like the average age was in the mid 70s. So we know, that some patients were well into their 80s in that trial. And that's the majority, a lot of our patients that even undergo DBS will be around that age. So we take it case by case, discussing with your primary care provider, but also like looking at medications that you're on, and the functional levels that you have, the disability that you have from the condition, and other like medical conditions that you do have that would place you at risk. But if anything, the focused ultrasound, honestly, of all the procedures, is probably going to be the safest again because you're not going to be placed on a ventilator, or under general anesthesia during the procedure. So there's less chance of having things like pneumonia, blood clots, or a cardiovascular event during the procedure.
Yes, I think the oldest patient I've heard be treated is 97. So you can get up there. This person is saying, I have tremor in my jaw and my head. You touched on hands and feet a little bit. Do you want to touch on your jaw? Will focused ultrasound help with jaw tremor?
Yes, I mean, we should expect benefit, but again, I don't think that with a single perhaps with the second one, it would be significant. But we do have to be careful because we don't if we aim the ultrasound too close to the head area, we may have like more dysarthria side effects. So like that's what we would check during the test dose. But with bilateral treatment, we would expect to have at least some improvement. Most likely it won't be into that 70 to 80% range here that we're quoting for the hand tremor, but it'll be like a reduction.
The Social Security Disability Insurance does not recognize essential tremor as a disability. There is a single mention of tremor on the neuro section of the website that is under the MS description. This person is wondering if you guys know or are aware of any efforts to push this description for patients who have severe impacts of their ability to work.
That's
You
that's
know,
an interesting question. And probably,
yeah.
yeah, go ahead, Dr. Yes.
No, I was going to say, I do have patients that have with very severe tremor that have either opted to not go through a surgical or maybe aren't candidates for it and have filed for disability. I think it's more about the description of how how the condition affects their daily lives and what they can't do. I don't, I'm sorry, I wasn't aware. I've never heard that it doesn't come up as an entity on Social Security, but I do have patients that are on disability for essential tremor.
The next question says, I am 30. I was diagnosed at 10, so the magnitude of my tremor is pretty bad. I recently learned about myoclonic jerks, and I'm curious if this is a separate thing I would have without tremor, or if it definitely or very likely caused by tremor.
So people that have, essential tremor for a long time can have other symptoms that sometimes can be part of, we used to think it was all just tremor in people that had essential tremor. We have learned over the last decade that people can have some other symptoms that can be part of this. And sometimes when people start very young or a lot older, at those two ends of the spectrum, they can have other symptoms. Now, sometimes people can have dystonia as part of their essential tremor, especially if they have head tremor as part of it. And so they can have like a head tilt or a little bit of what we call underlying torticollis as part of their tremor. And definitely can sometimes develop a little bit of jerkiness of their tremor. But if there is a lot of myoclonus, what they're describing sort of a jerky quality, make sure that you're seeing a neurologist or a movement disorder specialist. There are a couple of conditions where, it may not be essential tremor, but a little bit of sort of myoclonic or jerky movements underlying tremor or head tremor can be normal.
The next question is, this person seems to have focused ultrasound around 5 years ago and necessarily didn't see the results that they wanted to see and are asking what they should do now.
Yeah, so definitely there are options, so what we've seen in the field currently, it's still being debated as to what the best treatment option is. It's probably individualized at this point. One option is to repeat the focus ultrasound, and people have had a lot of success doing a second therapy in a delayed fashion. The other option would be to then proceed with DBS therapy. And so I think some of it will depend on the residual symptoms, if the tremor has changed in quality and severity, and also like the appearance on brain MRI to see like the shape of the lesion, how the brain appears. But yeah, I would say that both options are available.
How far in the MRI tube does the patient go?
So it's mostly focused on the head, obviously. So like you don't have to go all the way in. Most of the time, the patient's approximately to like maybe at the shoulder level. Then, so there's a lot of like in and out. And I see the next question is like, how long are you in the MRI for? So it's probably the same question. Probably the longest time is like on the preoperative MRI, where we're getting the study like not on the day of the procedure, but like prior to that. I'd say it takes about anywhere between 30 minutes to 45 minutes to obtain all the sequences. But on the day of the procedure, it's a lot shorter than that because we just obtain a short amount of sequences, meaning like images that are limited. And there's more like in and out. So maybe like 10 to 15 minutes, I would say.
Yeah, that's what I would say. I would say that first one is the longest one, about 10 to 15 minutes, and then the rest of them are super short and quick. Is focused ultrasound done at TMMC and Little Company?
No, only at the little company, Mary with Providence, so not Torrance Memorial.
Does HIFU help non-tremor Parkinson's side effects?
Non-tremor or non-motor, I think I was seeing here, non-motor. The newest indication, as Dr. Langevin was talking about, is for patients with Parkinson's, tremor, dyskinesias, you know, the dancing movements and some of the advanced symptoms of Parkinson's, the physical symptoms of Parkinson's, stiff, slow, the involuntary movements and tremor. So it has been shown to be very helpful for those symptoms. In terms of non-motor symptoms, so, you know, for those that don't know Parkinson's, you know, with Parkinson's, people can have a lot of symptoms that are not physical. Changes in their memory, changes in mood, fluctuations in blood pressure, changes with urinary function and constipation. And you know, unfortunately, the medical therapy sometimes doesn't get through that. So some of the medicines that we use to treat the physical symptoms of Parkinson's may or may not help a little bit, many times end up aggravating it. Same thing with deep brain stimulation. The focus is to treat the physical symptoms, and occasionally we'll get a little bit of benefit with the non-motor symptoms. And, you know, with focused ultrasound, again, the targets that are being used are for ones that treat the physical symptoms of Parkinson's. Having said that, you know, a lot of the medications that people with Parkinson's take can aggravate their non-motor symptoms. You know, they can give people mental fog, cognitive slowing, worsen their anxiety or depression, worsen their constipation. So the focused ultrasound, just like DBS, it may allow us to bring down the amount of medication that they take, so that some of those things, if they're impacted by the medications, can improve.
Great answer. The next question is, once the lesion is created, does it remain or dissipate over time?
It's a little bit of both. So like we definitely see a change over the first, several months after the lesion is created. Initially, like there's going to be a larger area that's apparent on the MRI scan that we follow. And that's usually the swelling or the edema is what we call it. Then that recedes and it becomes a small focus. So oftentimes we see a tiny hole, inside the area that was sometimes it appears to be closed off, like in certain patients. It just depends on how it heals.
Can Parkinson's be confirmed versus ET via a new alpha Zin test?
Yeah. So I for essence of time, I didn't include some of the testing that we have available, but as I mentioned, sometimes it can be confused, especially as patients get older. And patients maybe have subtle symptoms that can make even doctors scratch their head and say, are we looking at essential tremor? Are we looking at Parkinson's? So there are some tests available whenever we have a patient that maybe we're not sure. The one test that's been around the longest is a nuclear medicine brain scan that's called a DAT scan. So basically, it's an injection that works its way to the brain, and it tries to quantify how much dopamine a patient's making in their brain. And when they have Parkinson's, it's low. When they have essential tremor, it's normal. So that's one test that is available, and we do quite a few of them here to when somebody has tremor, if we're looking at essential tremor, Parkinson's. Over the last couple of years, we've had some newer tests that have become available. So the SYN1 biopsy skin test that this person is alluding to is a punch biopsy that we do. In Parkinson's, people have this accumulation of proteins over time in their brain, and we've learned that we can find it in the little nerves of the skin. So there is an in-office punch biopsy that we can do. that will help look for those. And if you have them, you have likely a risk of Parkinson's. If you don't have them, then it's essential tremor or a different condition. So yes, we don't use them on everybody. So sometimes the diagnosis is pretty clear cut, but whenever is that question, are we looking at Parkinson's with tremor, or are we looking at essential tremor? We have a few tests available.
The next question is, are you aware of the Willem ball? Do you see something tracking the magnitude of the tremor to be able to offset it as the answer for a mass market solution?
Yeah, so there's a couple of devices that are available. I haven't really worked with the Willem ball very much, although I am aware of it. So there's a couple of what we call neuromodulatory devices that are available. I think I mentioned the wrist-worn devices, which are devices that stimulate peripheral nerves in the arm, and they not only try to measure and dampen down a person's tremor, but they're thought to feed back to the brain and maybe decrease the amount of signals that are coming out to the periphery. There's a newer one that just came out that's called the Facilic, that's attached to the cloud. So it's supposed to be a little bit more personalized, not yet available. And the Willem ball is similar to that. It's a ball that is supposed to record the amplitude and the frequency of a person's tremor and try to counteract some of that energy. And people, I think they hold it or they use it for a certain amount of the day to see if it reduces their tremor. So there's a few devices like that out in the market that people can try. My experience with them, and of course everybody's different, my experience with them is that, like medications, they'll reduce the tremor a little bit, but if people have a lot of tremor, and none of these really give people enough control to be able to do things effectively during their day. If you have a little bit of tremor, a combination of these things might be useful.
We have one more question in the chat, so I want to remind everyone, if you have any last minute questions, please put them in now. But the last question is, my son is 18 and he has essential tremor. He has not seen a neurosurgeon. Do you recommend medication for essential tremor until he's old enough for focused ultrasound?
Yeah, I think so right now, because the FDA, unless Dr. Langevin has, a different take on this, but the FDA sets it as you have to be 22 for essential tremor. So as I mentioned, we've got a lot of different modalities. There's medications, I still at that age would have them see a, occupational therapist. What are the tools available, like these devices, like other adaptive techniques, strengthen their hands and, use weighted utensils, whatever we can do to see if we can reduce it. And at 18, we would really try to use the medication as sparingly. We don't want to give them any of the potential side effects people have, but usually maybe a multimodal approach to this until they're old enough, if they qualify, and at that point, if they want to be evaluated by neurosurgery.
We have a few more questions. Is the high food target the same for ET and Parkinson's?
Well, the answer to that question was yes, not a long time ago, but no longer now. So essentially for tremor, the target is the thalamus, both for Parkinson's disease and for essential tremor. However, this new indication for Parkinson's disease, like other symptoms of Parkinson's disease that are not tremor, is a different target that will help mostly with other symptoms like slowness of movement and rigidity. And there are certain investigators that are already looking into doing dual target type of therapy. So that's something that can be envisioned in the future as well.
Yes, lots of exciting stuff that is coming along. The last thing is more of a comment, but they said, greatly appreciate you all. Thank you so much for your time. I want to thank everyone else for being here as well and for participating in this. And you guys have been very engaged and asked wonderful questions. So thank you all for being here this afternoon. And I want to thank Dr. Langevin and Dr. Diaz for being here as well. And then, of course, again, please reach out to them on this email and look at their website and the phone number, and they'd be happy to answer any questions that you guys might have. So thank you so much, and I hope everyone has a great rest of their evening.
Thank you.
Bye, everyone.